So we have two experts. We have Professor Paolo Arcidiacono, who is the Associate Professor of Gastroenterology and the Head of the Pancreatic and Biliary Endoscopy and the Endosonography Division in the San Raffaele University Hospital in Milan. So yeah, right in the front of the COVID crisis. And then we are very happy to also have Professor Didier Lepelletier, who is the Professor and Head of the Hygiene Department in the University Hospital of Nantes in France. So if we can move to the next slide, I would like to show what what we will have is we have two presentations for you packed in one, and then at the end we have a question and answer session. So you have all been muted by me. So if you not have been muted by me, please mute yourself, because we have a lot of people in the room, and it would be very noisy if people start speaking. Because you are muted, that doesn't mean that you cannot ask any questions. Please ask your questions in the chat box. At the end, we will have a Q&A session, and we will address your questions. If we run out of time, because we know your time is precious, if we run out of time, what we will do is we will make sure that all the questions will be answered by our two experts, and that they will be shared later via LinkedIn. So we have a lot that we want to share with you. So therefore, I would like now to hand over to Professor Arcidiacono, who will share his experiences in how to treat the equipment during the COVID-19 pandemic.
Can you give me the slide, because mine is not working actually. Okay, so as you heard from the presentation, I'm working in Milan. Milan is a big city in the center of Lombardy, and Lombardy is actually the most involved region in Italy for COVID pandemic. These are the actual number of patients, infected patients in Lombardy compared to the rest of Italy. You can see right 1/3 of all the patients are coming from Lombardy, and the San Raffaele Scientific Institute, where I work, is a huge hospital, and today we are dealing with 300 inpatients for COVID, and among those 45 are in ICU, and the other 56 are ventilated in non-invasive modality. So a huge number of patients with COVID disease. And this is our division. So the numbers of our division, we are a very high volume pancreatobiliary endoscopy division. So we perform nearly 2,000 US procedures per year and nearly 700 therapeutic ERCP. And we are involved in a pancreatic cancer center activity, which is one of the biggest in Italy, leading to 300 pancreatic resection per year, and with a lot of oncological treatment. So for this high volume that we have, we are facing during these times, unfortunately, during the last 2 months, to a lot of patients with COVID disease, and for this reason, we need really to have a perfect and very clear schedule on how to manage this patient and how to protect ourselves and the patient from infection, and also from cross infection between our personnel. So you are aware there are a lot of publications presenting which are the best protective personal equipment that you need to wear during the procedure, but there is not so much on the how to manage after the end of the procedure. So this will be the main part of my talk. So what's happening when we start a procedure into our US PRCT endoscopy room? The room is a negative pressure room. This is very important. And outside the door of the room, there is this sticker which clearly signals to the outside that there is an ongoing COVID patient procedure. And as you know, ERCP is a very crowded room. We have a lot of people inside. At least 7 people are working in the same room at the same time. So particularly if you don't have the possibility to have an undressing dirty room, and so the process of undressing should be done inside the endoscopy room, there should be a clear statement, a clear way how to undress into the room, and who is going to undress first and who is going to undress last. So this is what we do usually at the end of the procedure. This is the room where we work. We have the technicians, the radiology technicians, who undress and exit the room directly into the radiology department. On the other hand, on the other side of the room, the 2 endoscopists at the end of the procedure undresses first. So the 2 endoscopists are the first 2 who undress and then exit the room. So into the room we leave the two nurses and the anesthesiologist. And what they should do. The first nurses is the nurse that is taking care of the instrument. So she has to clean outside the instrument, to suck the instrument with this cleaning disinfectant, and then unplug the instrument from the processor, plug the instrument, and it's important to cover the distal tip, which is very, very fragile of the instrument, and then put the instrument into this waterproof bag. And this waterproof bag is there's a sticker put on the bag clearly showing that this is a COVID positive instrument. Then the second nurse is taking care of all the devices, and so all the devices should be thrown into this hospital waste that they should be closed. And then the 2 nurses and the anesthesiologist take care of the patient that should go out from the room. So at the end, we start doing the undressing. The undressing is, to me, one of the most important things that you should do into the room, because this is the most important thing to do to be safe, because the cross-contamination of the endoscopist is performed here if you don't undress very well. So then you see that the nurse is undressing the second show cover, and then is taking out her waterproof gown, and it's very important how she's taking care of that. She's you see dropping that in order to always touch the clean part, and then again waste another pair of gloves, and then starts removing the face protection here. And this is the first cap, and then that she is going to remove. We always wear 2 caps, and then the first surgical mask that protects usually the FP2 mask. Then she removed the goggles, and both the face mask and goggles were cleaned afterwards. And then she's exiting the room, taking out the second show cover that she has to be able to go outside, clean from the room. And then you see there is another waste here outside. Then she's taking care of the FP2 mask, the first cap, and then at the end she is removing the long gloves, protective gloves. And at the end of each of these processes, the hand hygiene is a must that you need to perform very, very carefully. So we finish the procedure, then before taking care of the instrument, that we need that somebody will take care about the room, the endoscopic room cleaning. And we know from the literature that this cleaning procedure can be done with the standard disinfectant, the standard washing materials that you use normally. And so we can have our nurses who are taking care of the rooms are wasting all the tubes, all the things that have been used for this COVID patient, and then close this into this tank, which is clearly stated to be a COVID patient. Then there is a very careful cleaning of the instrument and all the furniture of the room to prepare the room for the next procedure. This is a very important procedure because reduce enormously the risk of infection afterwards. After the cleaning of the procedure, at the end of the day, we perform a clear sanitizing procedure of the whole room. And this sanitizing procedure is performed by an expert team of people who comes into the room and clean completely the room. We call it Protocol 0. So then we can pass to the journey of the instrument from our endoscopy room to the washing procedure. Oh, can we go back one slide? Is it possible? Sorry. Okay, that's good. Okay, so what happened? This is the nurse coming from the endoscopy room into the dirty corridor that we have and entering the washing area. So this is the nurse who is going to take care of the instrument. And the washing procedure is very, very important, particularly if we are dealing with an ERCP instrument, because as you know from the literature, the ERCP is the most contaminated procedure that we have to deal with in the endoscopic department. So we usually connect the instrument to this specific washing machine. This washing machine connected with the instrument can perform a perfect washing with a standard pressure of all the channels of the instrument in order to have the perfect cleaning of the instrument. Then, as you can see here, we usually prefer for all these kind of patients to have to work with a DEC instrument, like you see here. The DEC instrument is the instrument that is able to reduce completely to zero the possibility of infection in the working channel of the instrument. As you know, the most important and the most dangerous part of this area is the elevator part, and this DEC instrument by Pentax has a completely disposable tip with the elevator inserted inside. So when we remove the cap, we remove the elevator as well, and leaving, and then I show you in another part of the video, leaving a complete exposure of all the channels that you can use. So we are working on that, and then the washing procedure comes with the washing side, and then we can see that we're cleaning procedure is brushing everything outside is very important. And after the brushing, then we can start cleaning, the procedure of cleaning the instrument inside the washing with the working channels and so on. So we clean perfectly with this, and you see here, this is the distal tip. You see how is clear the possibility that you can use, and you can clean everything very easily without any problem of the elevator and so on. After that, we proceed to cleaning all the channels with this disposable cleaning scrubs. As you can see, this cleaning procedure is very important to be able to completely clean the working channel, all the channels of the instrument. You see, this is very important that we can do all this procedure completely from one side to the other, and you see here how it's easy to clean also this part. At the end of this cleaning part, we have also another part where we can wash completely again with the hydrogen disinfectant the channels of the instrument, and then after that we can put the instrument inside our washing machine, And so this is plugged, and this comes into our washing machine. You see, we have a double lumen washing machine with the dirty part and the clean part. So at the end of this process of cleaning, you can see the machine is closing. So at the end of this process of cleaning, the machine arrives at the end. And so on the other part of the in the clean part of our washing area, there's the opening of the machine, and the instrument is taken out from the machine by another nurse that puts the instrument on this area. Here, particularly for this kind of patients, we now prefer to be absolutely sure of the fact that the cleaning procedure has been performed, to store this instrument with these particular bags that I'm going to show here, that are very effective as you can see here, the machine is drying perfectly the working channels of the instrument, and drying the working channel of the instrument is very important because it gives you the possibility to avoid and to perfectly eliminate the film, humidity film inside the working channels. That could be a real area where the bacteria and viruses can stay. And then we put everything, we store everything, the instrument inside this plasma bag that are clearly and effectively sealed. As you can see here, the bag is completely sealed, and the bag itself is inflated with ozone and closed. This helps us to this procedure helps us to perform two things. The first one, we have an instrument that can be used in 30 days, because these bags that allow us to have the instrument perfectly clean and dry, and to keep this safe for 30 days. And the other very important thing, but Professor Lepelletier probably will discuss further on this, is that we know that ozone has the possibility, the capability to reduce the possible bacteria and viral inside the working channel by 99%. And so this means that you are, in these cases, absolutely sure that this instrument is perfectly disinfected from all the bacteria and all the viruses. So then we store this bag into this very small and clear and clean storage, and this can be used to transport the instrument from the washing area to the endoscopic area to perform another COVID patient. So this is at the end the journey that we have from the end of the endoscopic procedure, in this case ERCP procedure, which is our usual activities, to perform to a clean instrument to perform another patient. So thank you very much, and I now want to present that Professor Lepelletier is going to present the hygiene perspective. So I'll hand over to Professor Lepelletier. Thank you very much, and see you afterwards.
I try to keep the hand to get my slide. Yes. So what I would like to say in a few slides is about the risk assessment in endoscopy during this pandemic situation. Infection prevention and control have been shown to be effective to safe for both healthcare professionals and also patients, because you can easily understand that there is cross transmission between healthcare workers and between healthcare workers and patients, or between patients and healthcare workers. This is not limited to the use of personal protective equipment. We will about that in a few slides, but it's based on the transparent and detailed IPC strategy, risk assessment or risk stratification, the correct use of those protection, and selected interventions for patients at risk of COVID-19. A rational approach regarding limited resources is equally important. As you know, in this pandemic situation, you can have some limited resources, particularly for face mask or clothing. Healthcare workers in endoscopy units are at increased risk of infection by COVID-19 from inhalation of airborne droplets, conjunctival contacts, and feces and touch contamination. We will see that in few slides. Periendoscopic aerosol infections have also been reported, potentially placing upper gastrointestinal endoscopy among the high-risk aerosol-generating procedure that we call IGP. In addition, live virus has been found in patient stool, and angiotensin converting enzyme 2, that is the receptor used by the virus to enter in pulmonary cells, is widely expressed in the gastrointestinal tract. And in addition, healthcare workers may transmit the infection to their patients, as hospital-based epidemics have been worldwide reported. So endoscopy units should strongly consider temporarily postponing elective non-urgent endoscopy procedures according to local human resources and local policies that may depend on the regional national guidance regarding the pandemic. So what do we say about the coronavirus transmission? As you can see in this draw at the right of the slide, the virus seems to be transmitted by small droplets through sneezing, coughing, or when people interact with each other from some time in close proximity. And you know the distance of 1 meter in Europe, but the US CDC recommend to 2 meters of distance. There's droplets can also be inhaled or they can land on surfaces that other may come into contact with. We can get infected when they touch their nose, mouth, or eyes around 60 times by hour for a normal human, you know. So the virus can survive on different surfaces from several hours, 4 hours, for example, for copper, 24 hours for cardboard, up to a few days, 3 or 4 days for plastic and stainless steel. However, the amount of viable virus declines over time, around 99%, and may not always be present in sufficient numbers to cause infection from surfaces. So how do we approach the virus in relation to endoscopic safety? By preventing and controlling the risk of direct transmission person to person. As you can see here in this draw, when you are close together, healthcare to healthcare workers, that mean operators, for example, during hospital activity. Also healthcare workers to patients, or patient to healthcare workers during the endoscopic procedures. And also by preventing and controlling the risk of transmission by surfaces. For example, healthcare workers or patients during endoscopic procedures and hospital consultation. And after use, endoscopes can be considered at risk of contamination if the patient is positive for COVID-19 and without, of course, specific protective measures. What is about the inactivation with both biocidal agents? You know that this coronavirus is an enveloped one, and it can be easily inactivated by commonly used disinfectant. You can see in this table. And we can say that all the coronavirus are inactivated by 0.1% sodium hypochlorite or 60 to 70 ethanol products. And that's why hydroalcoholic products that contain generally more than 70% of ethanol are effective against SARS-CoV-2 virus. Here, a photo of my retroprocessing center in the Nantes University Hospital. We have 8 retroprocessors like this in these pictures. And as you can see, this is one of the 7 healthcare workers working every day in this center. This person, she is wearing a gown, daily clothes, gloves, mask. We'll speak about the 2 types of respiratory mask, and glasses. Of course, during this pandemic situation, only 2 of them are currently working, and usually 5 to 7 persons are working in my center every day. We only disinfect 30 endoscopes per day instead more than 120 in routine. Of course, in ICU, pulmonary endoscopy are done with single-use endoscope without need to treat the endoscope. And gastroenterologic and urologic endoscopies are only reserved in this period for patients with cancer or patients in emergency. What about the protection at the endoscopy room? Of course, only essential endoscopy personnel should be present in the endoscopy room, of course. And according to the patient's risk status, protective should include gloves, hairnets, protective eyewear, waterproof gowns, and respiratory protective equipment. And as you can see at the right of the slide, you have 2 types of respiratory mask. The first one that we call surgical mask for the main situation. And here the filtering facepiece mask only for aerosol germination procedures, for example, pulmonary endoscopy or high risk gastrointestinal endoscopies. So hand disinfection is a main procedure to control the risk of transmission, of course. As I told you, hydroalcoholic products are effective against coronavirus. And also you have to make a surveillance of patients. If you take care of a patient with respiratory symptoms, you have to call back the patient to ask him or her to take his temperature and to consult a doctor if she or he needs. For patients in hospital, in ICU, gastrointestinal examination must be done in the ICU. As I told you, pulmonary endoscopy is done with single-use endoscopes. So the virus is easily inactivated by usual virucidal products. So there is no additional procedures to improve during this pandemic situation to the disinfection of the material. The disinfection of endoscopy rooms, equipments, examination tables are to be cleaned with usual virucidal detergent disinfectant products. And after an endoscopic examination with symptomatic patients, it is necessary to open the windows for 15 minutes period, and the time to carry out cleaning with the usual products by the person present in the room or by a person with equipment, and particularly a surgical mask. So you can see in this slide a summary of all those equipments for the healthcare workers published by the ECDC, but the WHO published our own guidelines, and each countries publish guidelines about PPE for healthcare workers. So what are the key factors for good retroprocessing? As you can see, the bedside cleaning right after exam, then to transport endoscope to the retroprocessing room. In my hospital, we have 2 robots, so you can see here, to transport between units and the retroprocessing center in a quick way. Then the manual cleaning and brushing, automated cleaning and disinfection in a retroprocessor, and then to store endoscopes in cabinets or using plasma typhon, both to dry or to store endoscope. Then we adopt the plasma typhon solution. We have several materials to dry or to store endoscope. We have more than 200 endoscope in my university hospital. Currently, around 50 of the endoscope are stored in cabinets, and all other endoscope are stored using a plasma bag. And you have here the list of the different types of endoscope that are stored with the plasma bag. So of course, use of plasma bag is to minimize the risk of bacterial contamination through a highly effective drying mechanism from the endoscopic channels, and to reduce of endoscope retroprocessing cycle times. Last slide to speak about a solution by using ozone gas as a viral decontamination agent. As you know, many publications have been previously published on that topic. ozone is a natural gas easily generated in situ from oxygen or air and breaks down to oxygen with a half-life about 20 minutes. And as a gas, it can penetrate all areas within a room, including crevice, fixture, fabrics, and device, and under surface of furniture, much more efficiently than manually apply liquid spray or aerosol. The only significant disadvantages are its ability to corrode materials such as natural rubber or plunge exposure at high concentration. So in conclusion of my talk, endoscopy activity is currently very down because of this pandemic, of course. Only 20% of the routine activities is currently done, but routine activity is required for non-COVID-19 patients with cancer. Specific organizations are needed to protect patients and healthcare workers. Coronavirus is a fragile and enveloped virus that can easily be inactivated by commonly used disinfectants having virucidal activity for both contaminated surfaces and endoscopes. So there is no need to add some new strategy during this pandemic period related to the disinfection procedures. And routine retroprocessing of flexible endoscopes and endoscopic accessories should be performed according to published guidelines or your own hospital recommendation. So thank you for your attention.
Thank you very much, Professor Lepelletier. Sorry, my French is not as good as it should be. So I think looking at the time, let's see if we can also get Professor Arcidiacono back into the view. If he can share his webcam, so then we have the three of us we can still answer some questions then.
Here we are.
Yeah, okay, great. So good to have you also back. We have some questions from the audience. We have some questions from the audience. The first question is, good afternoon. Facing this pandemic, we restricted endoscopic activity, but we are now sure that the virus will not go to disappear in the near future. How are you preparing to increase the endoscopic activity in your units? How are you going to work to stratify and select patients and to maximize the duration of the PPE? I think it's a very relevant question. Who would like to say some words on it?
We don't know exactly in the future when we are be able to go back to routine activities. I don't know in Italy, but in France, the confinement will be lifted at the middle of May. All the routine medical and surgical activity are stopped. So we are only take care patients in a specific COVID units and also patients for surgical or medical emergency. So as I told you, our activity is very, very down today. Only 20% of the usual activity. But at the end of the pandemic, of the epidemic situation, we hope to go back to a normal activity. Maybe we are able to test patients. Maybe we will have a vaccine to protect patients and healthcare workers. So I think during the next months, we'll be able to go back to a normal activity. I don't know in Milano what is the.
I agree with you. Actually, we have the same strategy that you have shown. So we are working only on cancer patients and on the inpatients that should perform any kind of endoscopic procedure. For the next future, I think that since we don't have the vaccination yet, I think that our strategy will be to to clearly separate two areas. So in the endoscopy, so we will have, like in the hospital, one COVID-free area. So we will have a COVID-free endoscopy area and and an area for COVID patients. And for the outpatients, I think that we will provide the patient when they will come to the unit to perform standard ambulatory outpatient procedure. We will test the patient with this new serological quick test in order to see whether the patient has only IgM elevated, so probably is infected, or if the patient has already done all the infection. So, and in the future, I agree with you, probably all the physicians and all the health workers will be vaccinated as first, and then when all the population will be vaccinated, we will come back to a normal activity.
Okay, thank you very much. We also have some questions, and I think it was also presented about the negative pressure rooms. So can you please comment a bit more on this? So what about the negative pressure rooms? Is it mandatory for aerosol generating procedures? And then another question was also related to this, is also about the negative pressure rooms. So what is the recommended procedures? And in case of air cycles, what is the recommended air cycle to be maintained? So both of them are addressing the fact for negative pressure rooms.
In France, that is a debated questions. There is guidelines that recommend to put in negative pressures or the operating room or ICU room. I don't know if it is really efficacy, because there is the risk of bacterial infection, for example, in the operating room, and to keep a positive patient, and the need to protect the risk of COVID-19 infection, and put with a negative patient an operating room. But I think patients are intubated when they are in a operating room, and the risk of aerosolization of the COVID-19 is very, very low. So I'm not sure that's its efficiency to get a negative pressure in all the rooms in hospital to practice endoscopy or surgical activities. I don't know your opinion in Italy, but I prefer to have an atmospheric pressure.
We actually have the negative pressure in our rooms, because our rooms in our department, the therapeutic rooms are built like operative rooms. So we have negative pressure. We have a very high level of changing of air inside the room, in order to have the room very, very clean, the air in the room very, very clean, very quickly. For this reason, we usually our infection control service inside the hospital told us that we need only 20 minutes from the end of one patient to the beginning of the next patient to have the room perfectly clean by the air before. This because we have the two things: the negative pressure and a very high frequency of changing of air inside. But there is a lot of debate. I agree with you, a lot of debate on this area, particularly because in most hospitals the endoscopy department doesn't have a negative pressure room. So guidelines suggest to go into the OR if you have to deal with a patient, with a COVID patient. But this is, from a logistic point of view, could be very, very difficult and not cost effective in the politics of the department.
Yeah, and it also depends on the technical possibilities.
Yeah.
Yeah.
Agree.
Okay. Thank you both for the answers. Another very relevant question, I think, is referring to the testing of patients. So the question is, do you think COVID-19 PCR or fast test prior to endoscopy may help us resume practice and keep a good productivity in our endoscopy units? Does this seem like a reasonable approach?
I think
yes.
Okay. You are the expert.
Oh, yes, PCR can help to diagnose patients, but we must be very cautious with the results, as we know that there is 30% of false negative patients at the beginning of the disease because the virus is not present in the nasopharyngeal area. So I think in this pandemic situation, we need to organize the activities, have all the patients can be suspected to be COVID-19 positive. So we need to organize the admission, to wear some clothes and masks, to wear gowns, to use hand hygiene, and because if you only take care of patients with positive tests, maybe you will be surprised in the future with new cases by taking care of patients without, for example, symptomatic respiratory signs. As we don't know exactly, but between 20 to 50% of patients are asymptomatic.
Yeah.
I completely agree with Professor Lepelletier. The other thing that we must keep in mind is that a certain amount of patients, nearly 30% of patients, have the virus into the gastrointestinal tract and not in the nasopharynx, and so this could be a big problem, particularly if you perform upper GI or colonoscopy as well, because this patient can infect the physician or the staff during the colonoscopy because the virus is inside inside the colon and not the nasopharynx. So probably the nasopharynx tampon could be negative, but the patient is positive in the gastrointestinal tract.
Yeah.
And also we don't know how long a patient is contagious after the disease. We don't know. Maybe 1 week, 2 weeks. What is the risk by the pieces, etc., etc. We don't know currently.
Okay, thank you. Thank you very much for your comments. I think we have time for one last question. So there are many publications, mainly recently from Italy, confirming the advantage of ozone as a viral decontaminant. What is your advice here in relation to COVID-19? And do you also see any applications of this advantage in endoscopy in the future?
I think that I agree. There are several publications recently performed, but there were also other publications during the SARS in the infection. And what we know is that ozone is very effective in destroying most of the bacteria and the viruses. So I agree, and the guidelines said what Professor Lepelletier has already said, that the COVID virus is very can be destroyed by the standard procedures of disinfection and washing procedure. But I think that the drying procedure that you can have with the ozone machine is very important, because not only for the viruses it's important, also for the bacterial infection, and particularly if you are dealing with ERCP duodenoscopy instrument. We know from many publications that there is a very high risk of infection using this instrument, if this instrument has inside a film of humidity into the bacteria that can be filled by bacteria. So the drying procedure and the ozone filling of the channels will be for sure in the future a must probably for the standard disinfection and storage of this instrument, particularly if you are dealing with immunodepressed patients. We have a lot of patients here with blood problems and so on. So immunodepressed patients. So this patient probably will be the one who will be treated by this particular instrument.
Okay, thank you very much. So we have reached the end of our time slot, unfortunately. So with your last answer, you also answered some of the questions that were asked about the biofilm progression inside the endoscope. So thank you for that as well. As we mentioned beforehand, unfortunately, we cannot answer all your questions in this session, but make sure that we will forward all the questions to Professor Lepelletier and Professor Arcidiacono. They will be answered. We will get back to you. They will be shared in LinkedIn. Having said that, I would like to very much thank our two international speakers, Professor Lepelletier and Professor Arcidiacono. And I would like to end this session. Thank you so much for your attention. And we love to see you back in one of our future webinars. Thank you so much, and we really hope that this was useful for you. Thank you and goodbye.
Thank you. Bye.
Bye-bye.
Bye-bye. Thank you.